The three main points are that of accuracy, precision, and radiation exposure. So with a freehand technique, no matter how good you are, there's always going to be a certain element of inaccuracy. The pedicle that you're using to put the screw down is only a maximum of around about 7.5 millimeters, if that, and sometimes there's even smaller, especially with complex deformity. So your ability to put a 6.5 or 5.5 millimeter screw down that small channel, you have to be very, very accurate in doing so. So freehand, you're just purely relying on your own experience and feel as you go down that pedicle. So you really need some type of image guidance. If you're using fluoroscopy, which is simple X-rays in 2D C-arm, you're only getting one view in frontal plane, one view on the side plane. With 3D navigation, what you're seeing is a three-dimensional image of the spine and be able to navigate down that pedicle very accurately. I'm a great believer in navigation. I've used it, as I said, for almost a decade, and for me, it's my regular practice. For me, it gives me extra precision and accuracy. It reduces my radiation dosage as well, and I think it gives much better outcomes for my patients. But we also use it as a teaching tool for our juniors. So we have to make sure that we don't rely on navigation completely, and we still have to rely on the old-fashioned techniques that we learned when we were juniors and pass that on to them as well. So at Stanmore, we currently have the O-arm and the stealth station navigation system. With any navigation system, you always have to have, firstly, something which acquires the image, which is preferably 3D, and you also have something which interprets the image and allows you to navigate on the basis of the images that have been acquired. The best images acquired are those which are obtained on the table itself. So not ones that you've done previously that you try and match, but the ones that I've done with the patient lying down on the table. What the O-arm uses is a cone beam technology, which is similar to CT, to obtain high quality, high definition images, which give you a three-dimensional picture. There's lots of other image acquisition systems out there as well, like the Aero or the BodyTom as well, which also provide very high quality images. The reasons why a particular institution chooses, let's say, O-arm versus anything else is really due to what they normally use within the hospital itself in terms of implant technology, what they're used to, and who was first on the scene. It used to be a barrier was that people were very stubborn about it and weren't willing to open up their minds to the technology. I think that barrier has changed considerably over the last 5 years. The biggest barrier at the moment really is cost. The cost of, let's say, a navigation system, let's say O-arm and stealth station navigation alone, is in the region of around about 700,000 all in. By the time you buy the O-arm, the station itself, the consumables, the servicing, etc. A robot's even more so. You're talking $1 million plus. And within a cash-strapped NHS environment, you have to make a very good business case and find the funds to be able to show that it's something that's worth investing in. And that's why during my presentation I was trying to show papers where we're justifying the cost of the O-arm. Not in terms of trying to find money from a source, but saying you're actually saving money by reducing poor outcomes for patients. So if you have to take a patient back to theatre due to a misplaced screw, you don't only have to pay for the extra screws that need to be put in and taken out, but you're paying for the cost of increased length of stay, etc. as well. Standard fluoroscopy only gives you pictures in AP and the lateral plane, whereas obviously 3D, you're taking multiple images and you're able to build up a whole 3D reconstruction of the spine. Now you can navigate off 2D pictures, but you have to be very careful on how you interpret those images, and there's always a slight leeway for error there as well. One of the biggest things, of course, is when you're using 2D without navigation, and we predominantly use that for minimally invasive surgery. We're submitted as a surgeon to radiation exposure, as is the patient as well. With 3D image acquisition navigation, you do the image acquisition without you being in the room. So only the patient's exposed to that, and as a surgeon, you're not. And then when you come and put in all the screws, etc., that's done without any X-ray. So the surgeon exposure is dropped to almost zero. One would say also that perhaps then the patient's exposed to more radiation, but in effect, if you're using 2D fluoroscopy and doing lots of shots anyway, by the time you do, let's say, 10 screws, you probably have done as much, given them as much radiation exposure as you would during an O-arm spin.